All right, here we are. We made it to the last mini lesson for chapter 5. This one's going to cover the topic of integumentary repair, burns, and skin cancer. So the first slide is just a little 4-step process. They're showing the general pattern of what happens to your skin when it gets damaged. Now they're just showing like a little slice, like maybe, you cut yourself when you were cutting an avocado or a piece of toast or a bagel or whatever. But this could be true for any abrasion and things. And the level of repair is going to be proportional to the level of trauma. So clearly just a slice is going to repair itself a lot better than a big abrasion and a whole bunch of severely damaged tissue underneath. So the first thing is when you cut down deep enough through your epidermis into your dermis, this cut looks like it's going all the way down to the subcutaneous fat or hypodermis layer, superficial fascia, all of those terms, you're going to bleed. So blood is going to damage the blood vessels. It's going to bleed into the wound. And one of the characteristics of blood is going to make that blood clot, right? So we saw that in the positive feedback loop, the platelet plug. We didn't learn about actual clot formation yet, but you'll get this scab. So that kind of temporarily halts the bleeding. That's the positive feedback of maintaining homeostasis of your blood staying in your body and not pouring out all over the place. You're going to get inflammation. So all of the inflammatory stuff that we talked about at the end of chapter 4, that's all happening. It's just not visualized specifically in this picture, but you can see right here, it talks about the inflammatory response. What does the skin do though? So then a few hours, so the scab has formed after a few hours. Now those stratum basal cells, this is the coolest thing. So you have these migratory epithelial cells. They are just mitosising. Is that a word? Going through mitosis over and over again, producing these new cells. And they know, however they do, they know to migrate down underneath that scab. So they will go down as far as they need to meet each other. And so basically we're trying to return that continuity of the division between epidermis and dermis. In the meantime, granulation tissue is going to form, which is very vascular. Blood vessels are kind of growing into the area. Macrophages are coming in. Fibroblasts are coming in. We're trying to get all of the workers there to repair the tissue. All right, so then in step 3, or about a week later, the epithelial migrating cells have met. They're starting they're just going back to what they would normally do, making stratum basal and spinosum and granulosum. And in the meantime, as they're doing that, it's pushing the scab up further and further, which probably is going to get worn off. Don't pick your scabs. Just let them fall off naturally. And underneath, we have those fibroblasts laying down more collagen fibers. So they're doing their job, laying down collagen fibers. It's helping to push up the scab and the epidermis. And so then after a couple weeks, the scab will have fallen off, and you may have some evidence of that trauma with what we call a scar. And underneath that is what we call scar tissue. Now, if you'll notice, it's obvious, there's a clear delineation between the normal dense irregular connective tissue and the scar tissue. It does a pretty good job. Those fibroblasts cannot turn those dense scar tissue into the same exact pattern that you had before the injury. But they do their best, and they usually lay it down a little bit thicker, maybe more linear. So viewing through your epidermis, it's going to look a little bit different. And that scar may last a couple weeks, and then it might go away. It's just going to depend on the severity of the injury. So you've probably cut yourself hundreds of times since being a child age, but you're not covered in scars. So your body has a way of just kind of letting those fade. Now, if you had a very deep wound as a child, you still may have, or a surgical wound or an incision or something, that could be so much repair that it's not going to fade away after you're aging and, recycling and all those kinds of things. So usually the more deep the injury is, or the more scar tissue that's left behind in repair, the longer that scar is going to last. But most times you're not going to have scars. If it's just a superficial wound, it might have like a little white streak for a couple weeks, and then it just kind of fades away. All right, that's a repair of the integument. It's awesome. This self-fixing, totally waterproof or water resistant, it's not totally waterproof, keeps out bacteria, keeps out viruses for the most part, self-healing. It's amazing. I love our integumentary system. Okay. Sorry, I should have given a graphical warning. There will be some kind of graphic pictures coming up in our burns. So when we talk about burns on our skin, there's usually 3 degrees. First, second, third degree burns. You've probably heard that before. You might also hear them as thickness, partial thickness burns and full thickness burns. First and second degree burns are partial thickness. The reason why it's called partial is because it does not completely destroy all the way down past the dermis. In first degree burns, like sunburns are an example of those, the damage only happens to the epidermis. If you'll notice, the basement membrane, right, our squiggly boundary, is completely intact. Everything below that is a-okay. The trauma is happening above that, which is fine because you're killing off dead tissues. I don't want to say it's fine, it hurts. And repeated first degree burns can lead to more damage. But if you're leaving that stratum basal intact, you're going to be able to repair that pretty easily with minimal scarring or with minimal damage to your body. Okay. The second degree burn is also a partial thickness burn because if you'll notice, we still have a little bit of intact dermis underneath that. So second degree burns go all the way through the epidermis, partially through the dermis, and you typically are going to see blisters associated with second degree burns. And what is a blister, you might ask? Well, if you notice, here is the boundary between dermis and epidermis. That eggshell intersection has separated, filled with fluid that is the result of the inflammatory process. Your body's response is to leaky vessels, right, to produce a lot of fluid, and it gets built up and it sits in between the epidermis and the dermis. Your accessory organs are usually still intact. So sweat glands are intact, your hair follicles are still intact. They might be damaged from midway through up, but they're not completely destroyed. Okay. The next picture, I'm just going to show you the diagram, and then I'll show you an example of an actual third degree burn. So third degree burns are considered partial because the trauma goes all the way down past the dermis into the underlying tissues. In this particular example, it's gone all the way through the subcutaneous, that subserous fascia, one of those fascias, I can't remember off the top of my head, and it has gone actually down into the layer of muscle. So this is what we call a full thickness burn. It's completely through epidermis and dermis and into the underlying tissues. Your sweat glands are completely gone. Your hair follicles are completely gone. A lot of your nerve endings are completely gone. So right at the site of a third degree burn, you may not actually be feeling pain because there's no pain receptors left to send signals. The surrounding areas might be very painful because in second degree and first degree burns, those pain receptors are still intact. Now, again, graphical warning, there is, I will show you a picture of an individual who's got severely burned on his torso. And so this area here is probably the likely area of third degree burns, but we can still see some intact skin here. So those might be more of the second degree burns. So usually white, ashy, or dark ashy coloring is usually associated with third degree burns. And a lot of times, I'm just going to move away to the next slide. I can't go backwards, but I didn't want to have that picture up for too long. Third degree burns are really hard on the patient because you've lost your protective barrier, that cool self-repairing barrier that we just talked about in the repair section. And it opens you up it opens you up to infection, but the biggest threat to people with large scale burns on their body is dehydration, fluid loss, electrolyte imbalance. So it's really hard to maintain those things when you've lost your waterproof coat. And then also infection, you've lost your physical barrier. This particular slide, I brought it up. I can't remember how I learned about this, but it was a couple years ago. It reminded me, I'm kind of like a Star Trek fan. I like to watch Star Trek, and I always liked their dermal regenerator. So if you're a fan of Star Trek, somebody gets a wound and they take out their tricorder and they figure out the problem and they get their dermal regenerator and they go and then the superficial wound is healed, whether it's a cut or a burn or whatever. So this is, I guess, our modern day version of a dermal regenerator, and it's like it's a skin cell gun, basically. So what they do is they take the patient's own cells, some of those stem cells from like the stratum basal, they make it into this little cocktail. They let these cells grow and grow and grow in the lab, and they put it into this little gun, And then they basically spray the patient's own stem cells over the wound to help repair the large scale damage that was done. This is a before and after, and I put this link there if you wanted to follow it, this lab biotech company, stem cell gun Renovacare, looks like. But I think if I remember the story correct, this was a police officer, a firefighter that got injured on duty, helping somebody. I can't remember the story, but you can see he's got some severe damage all the way along his arm, which would typically require a lot of grafting, which is hard to do. And this is, I know my head's kind of covering it, but you can see pretty well, this is the same arm after using this stem cell gun. So amazing. I love this story. And it's kind of Star Trek-y, so that's pretty cool. All right, so those are our discussion on burns. First, second, third degree. First and second are partial thickness. Third degree is third thickness. Just destroys everything that's part of your integumentary system. The last discussion is skin cancer. There's 3 types of skin cancer your book discusses. We have basal cell carcinoma, squamous cell carcinoma, and malignant melanoma. So we're going to go through each of those and then kind of preventative measures that everybody should be taking to make sure that you are keeping yourself safe from skin cancer. Basal cell carcinoma is the most common type of skin cancer. It is usually caused by exposure to ultraviolet light. And if you'll notice the name basal cell, this is your stratum basal or stratum germinativum cells have been damaged by UV light. They've mutated some proteins and the cells just continue to grow out of control. That's what cancer is. And carcinoma just means cancer of the skin or epithelial tissues. So the survival rate for this is pretty high. If you can catch it early and it doesn't metastasize, you can usually just get it removed and that's the end of it. I believe it has a 5-year survival rate of 95%. So 5-year survival rates are typically how they kind of scale prognoses of people with cancer. So if you get it taken care of, in 5 years, there's a 95% chance you'll be cancer-free and you'll be good to go. The next one is squamous cell, right? Squamous cell. So these are going to be cells probably of the stratum spinosum, because again, stratum basal and stratum spinosum are the only cells that actually actively go through mitosis. Maybe a few in the granulosum, but we're not ever going to see a cancer of stratum corneum cells because those cells are already dead, right? So squamous cell carcinoma is cancerous of the stratum squamous, the keratinocytes typically of the stratum spinosum. Also, let's see, it's not as common as basal cell carcinoma, also caused by exposure to ultraviolet light. Like you can see nose, head, hands, arms, those types of things. It also has about a 95% survival rate if caught and removed early. The last one, this is the bad guy. So this is called malignant melanoma. This is when your melanocytes become cancerous. So again, enough UV light exposure, sometimes it's genetic, but mostly due to overexposure of ultraviolet light, turns those melanocytes into cancer cells. And again, cancer cells just means mutations have affected their cell cycle. They cannot go into the G0 or stop phase, and they just go over, they just make more and more of themselves. They're usually darker in color because they are the cells that make your melanin. So if those cells are growing out of control, then they are continuing to make melanin out of control. And so the melanomas are typically darker in color, splotchy, irregular borders, larger in size. They grow very quickly. The 5-year survival rate for these, depending on when you catch it. So if you catch a melanoma before it's become malignant, just like it's just localized in that one mole or freckle, the 5-year survival rate is 99%. So it's even better than the other 2 types if you catch it before it metastasizes. And metastasis just means the cancerous cells leave their primary tumor and go to somewhere else in the body. If your melanoma metastasizes and becomes malignant, which means it has metastasized, your 5-year survival rate drops to 14%, which is a huge reduction in your prognosis to be able to survive that. So once this melanoma spreads to other parts of your body, it just goes crazy and ravishes your lung or your brain or your bones or your heart or wherever those malignant cells end up landing. So that's why it's super duper important to keep an eye on your body to check for any of these types of cancers, because they all have negative outcomes. Malignant melanoma is just the worst if metastasis does happen. So I usually try to talk about this. I forgot it's A, B, C, D, E's. I added the E on the bottom, but not on the title. So A for asymmetry. So if you have a freckle or a mole that's normally, so that's symmetrical, right? Our line of symmetry. If it's kind of like this, that's not symmetrical. So asymmetry. Border, if it's a nice smooth border like this, again, that's normal. If it's a wiggly border, that's not normal. Color, if it's homogeneous, right? It's all the same shade of brown, that's normal. If it's splotchy, or if it has white or black or dark marks, or it's kind of mottled, I can't go back when I'm recording videos, but if you want to stop and go back and look at those examples, you can. Diameter, you're looking for things bigger than the end of a pencil eraser, right? So here's a pencil eraser. So that's about the size. Anything bigger than that needs to be checked out by a dermatologist. And the E, this is supposed to be change, not cha. E for evolution, change over time. So let's say you have something like this, and then in a couple months, you see it kind of getting a little bit bigger. And then a couple months, it's now kind of getting a little bit bigger, and now it's splotchy. This, not exclamation mark, wrong punctuation. This needs your attention. We have cell phones, right? And you have the ability to take a picture, put the date or date stamp, or put, a dime or something next to something. You're like, I'm not sure about that, but I don't think I need to go to the doctor and get it checked out right now. So I'm just going to take a snapshot, and maybe every month, like the last day of the month, you're just going to take a snapshot, put that dime next to it, take a snapshot, and then compare. What did it look like a month ago? What did it look like 2 months ago? If it's the same, it might be a little bit big and it might be a little bit mottled, but if it's not changing at all, maybe you can wait until your next physical or your next yearly checkup. But if it's changing in like a month or 2 months, that's a good indication that you should go and have a professional, like a dermatologist, take a look at that too. Just get it checked out. You might get a biopsy and they say, oh, it's fine, or oh, let's get that removed before it goes any bigger. Okay, so that's it. That's our last lecture for chapter 5. Way to go, guys. It is chapters 1, 4, and 5, which are the material that's going to be on your first exam, which corresponds to a lot to what you're doing in lab. 1, 2, 6, and 7, I think, or 5 and 6. I don't know the lab numbers right off the top of my head. So please send questions, send emails, come to a Zoom office hour, talk to me during lab time, because your first exam will be over these first 3 chapters. All right, I will talk to you later. Bye.